Good afternoon, everyone. My name is Elena Kussler, and I am the program coordinator at the Parkinson Association of the Rockies. Thank you so much for everybody who's joining us today, including Dr. Solis-Cohen, who's going to be speaking on medications and treatments kind of categorically today, which it's a really interesting topic, and it's fascinating to see how different medications interact with the brain. So just a couple of housekeeping things for my part. We will be holding the questions until the end. It just works better in this format. And there are a couple of different ways that you can do that. One is to navigate over to your control panel. It typically pops up on the right side of the screen. There should be a drop-down menu that has a questions tab. You just go ahead and type in your questions. If it's a technical question about sound or anything, I will answer it. It pops into me and I can answer directly. If it's a question with regards to the topic, go ahead and type that in. I will hold it till the end and ask it during the Q&A for you. The other option to ask questions is to raise your hand and ask the question verbally. What you'll do is you'll go ahead and raise your hand. I will unmute you during the Q&A session and you can ask your question directly. If you choose to do this option, please make sure that your computer is equipped with a microphone so that way we can hear you. There will be a follow-up email with a recording of this session as well as the handouts that are available. If you go over to that same navigation menu, there's a handouts drop-down menu. There's a couple of different things there, including a flyer on our virtual Vitality Walk. This year we're not able to have our Vitality Walk in person, unfortunately, but we will be hosting a virtual Vitality Walk and we'll be having some different programming on there so that you can listen in on the 7th of June. So go ahead and take a look at that. There's also a full list of the available online programming that we have, including other educational webinars, have a list of the exercise classes that have gone virtual as well. So included in those educational seminars, we have a couple of them coming up. One, we have a series happening that is called Master and Commander of the Good Ship Parkinson's, and it's a conversation with Greg Richer. The first one was actually yesterday, but it's a series and we're having it every Wednesday of the month through the month of May at 2 p.m. So come join us. The topic is more on how to track the different factors in your life that are helping you live well with Parkinson's. So it's a really neat program. Join us on Wednesdays through the rest of May. The other program that we have in a week, it's actually a week from today, is a webinar on managing stress and anxiety. I know we're all a little stressed and anxious right now, and especially as things start to open up, it's important to learn a little bit more about those topics. So that will be next Thursday, May 14th from 2 to 3 p.m. All of these programs are listed on our website. Go ahead and visit www.parkinsonrockies.org/online programs, and it should just pop, and that same list should pop up. So that, I believe, is all from me. So without any further ado, I will transfer power over to you, Dr. Luisa Solis-Cohen, and we should get going. Oh.
Hi, everybody. Can you hear me?
We can hear you.
Okay. So I'm Dr. Solis-Cohen. We're talking about the ins and outs of Parkinson's medication, and I'm hoping everybody's seeing this well. The really hard part of Parkinson's medications is there are just so many of them, and they all do something a little bit different. And it's hard to know which one's right for you, what should you gravitate toward and steer away from. And so I want to kind of provide you with some education about how the medications interact with the body, what are the side effects, what are the pros and cons. And always the disclaimer when we're talking about Parkinson's medications is that everybody's Parkinson's disease is different. Everybody looks different, everybody has different symptoms, and everybody receives these medications differently in their body. And so it's important to take the individual person's situation and discuss it directly with one's physician to make sure that you're on the right path, that these medications are being received well by a person's individual body, and that we're taking this on an individual basis. So here are the objectives for today. We're talking about Parkinson's disease pathophysiology, which is basically this kind of fancy word for what kind of changes happen in our body to create Parkinson's disease and what underlies this disease process. And I want to start with that so there's an understanding of what happens before we talk about what in the world do these medicines do to modify that process. I don't think we're going to be taking a break today, so I think maybe I'll get a text from Alina about whether or not we should or could take a break. And then we'll talk about motor fluctuations and advanced therapies in Parkinson's and some ideas for things that are coming down the pipeline. So I want to start off with talking about how does the brain actually work, and I want to challenge your idea of how that happens a little bit. So we generally think about neuroanatomy as the brain being composed of different areas of function, or as we call them, lobes of function. So there's the frontal lobe and the occipital lobe and the temporal lobe, and we generally think that each of these lobes does something different. And if you kind of pull apart the brain in half, there's these inner structures that we call the basal ganglia, and you may have heard of this before in terms of this part of the brain that allows fluidity of movement. I hesitate, Alina, because I don't know if they're seeing this sidebar blocking their slides or not. I just want to make sure they can see the whole slide. So maybe you can shoot me a notification if everything looks good on your end.
All clear here.
Okay, good.
Yeah.
So what we're going to do is we're going to take a step back, and instead of looking at the brain as kind of like these lobes of function, we're going to actually think about them as this kind of spider web network. And so we kind of think about the brain, and we need to think about the brain as being these discrete little areas that connect in a highway type of connection. And it's a very fast working system that modifies to what we do. And if you kind of take this, oh, I see. I have to go back and forth every time I want to use the spotlight. All right, sorry, learning curve here.
And we can see the pointer, just so you know. So if you just want to use that, it works.
Oh, you can? Okay, yeah. Perfect.
Mm-hmm.
I just can't advance it when it's in that mode. So now I'm having trouble advancing to my next point in the slide.
Go ahead and click one more time on there and see if that works.
There we go. Okay, so we basically, this next picture here is a zoomed in portion of what you saw here over in this schematic, and it basically shows us what things look like in this cartoon iteration. So we have a cell body, which is one of the building blocks of the brain, and we have it has these projections or these arms that travel in all sorts of different directions. And in this picture, we see this highlighted region here, which is basically showing us that one cell connects to another cell by traveling along this projection, and there's this special area between cells that we call the synapse. And so that synapse, if you kind of take this and you blow it up, you'll get this kind of a picture where one cell's long projection connects to another cell's long projection. And there's actually this tiny little gap between those, and that's this area that we call the synapse. And so one cell has to connect to the other and talk to it across this gap. That gap is so tiny, it's so much more tiny than the edge of even a paper, okay? Let's see next if I can. Perfect. So the synapse is blown up even further here, and we see this gap between one cell up here and the other one down here. And how do neurons or cell bodies talk to each other across this? Well, they often use something called a neurotransmitter. So neuro from neuron, meaning cell, and transmitter, meaning that that's what they do to transmit a signal across that gap. And one of those neurotransmitter is actually something that we call dopamine. So you'll see that this is a dopamine producing neuron, and it's sending its signal to the next cell across this gap that we call the synapse. And here, over here, is this picture of what a neuron typically looks like, although there's many forms and shapes, where there's a big cell body, there's this big long projection that's sometimes called the axon, then there's many little cell body, or I'm sorry, axonal endings that have, each has their own synapse. And so if you kind of highlight it here, you'd get this. And then there would be another cell at the bottom of it receiving its message. And so important in movement is that this system works well, that there is enough dopamine to transmit a message from one cell to the next. And so let's take it back to Parkinson's. Let's take it back to, okay, we learned a little bit about how brain cells work connecting to each other and talking to each other. Well, what's different about that in Parkinson's, and why is there a problem? So we'll take you over to the right part of the screen here. And I'm going to see if I can make, oh, I can, perfect. What we see on the top is that one cell talking to the next cell requires this amount of dopamine to transmit that signal. And the bottom portion of this drawing here is telling us that in Parkinson's disease, we know that there is a reduction in the amount of dopamine that's available for cell-to-cell transmission. And it's that reduction that ultimately leads to a movement disorder. So you may have a shakier movement, a less fluid movement, a more rigid or slow movement. And we know a little bit more about this process because of work that anatomists have done in the past, looking at brains of individuals who passed away with Parkinson's disease. And the very peculiar part of their brain that was different was the area that we call the substantia nigra. And you may have heard of this term before in reading about Parkinson's disease. This is a part of the brain that's generally responsible for making a lot of the dopamine that we use both there and elsewhere in the brain. And the difference between a person's brain without Parkinson's, kind of shown up here, and one with, is that that area of darkness is attenuated down here. And that area is the substantia nigra, the dopamine producing part of the brain. And therein lies the difference. And you may have heard before, but I'm just getting Alina's text. Okay. That area of the brain is called substantia nigra because the anatomist literally said this is black stuff, and so substantia, substance, nigra, black. It's as simple as that. Now, what's causing the loss of the substantia nigra, of the dopamine producing neuronal cells? We do know a little bit about what's going on there, and we see that the problem comes from the production of an abnormal protein. So we see over here, I'm turning your attention over here, here is basically an anatomist took a really thin slice of brain, and one of those cell bodies, I'm going to outline it for you here, hopefully you can see it, and it has a projection going up and a projection going down. And this brown part that's within the cell is the abnormal part. That's something that we call a Lewy body. And the Lewy body is basically a conglomeration of abnormal protein that interferes with how the cell produces, packages, and ultimately distributes dopamine to the next cell. So it basically kind of causes the traffic jam in the cell so that it doesn't function well, and sometimes it leads to its complete inability to function. So now we kind of understand, okay, we need normal amount of dopamine. We understand that dopamine's not being produced because the cell's getting mucked up with these things called Lewy bodies, and that's what's causing the problem. No, I just labeled that up there. Okay. Okay. So how do we bypass this? How do we fix the problem? Knowing that the crux of the problem is a paucity of dopamine, how can we get around it? What medications can we make to help solve our problem and help treat our symptoms? So if you think about it on a theoretical basis, there's a couple different things that maybe we should think about. So one is, why don't we just give a person dopamine? Like, if there's a lack of it, let's just give more of it. And that sounds like a really great idea, but it just doesn't work. And the reason it doesn't work is because dopamine is a chemical that does not cross the blood-brain barrier. So all of our brains are covered by a barrier that's kind of like if you had cellophane around the brain. We call it the meninges, and the job of the meninges is to protect the brain from harmful chemicals. Well, dopamine just happens to be big enough that it's not allowed to cross that blood-brain barrier. So unless you administer it directly into the brain with an invasive procedure, there's no way of getting dopamine to the brain in that fashion. So instead of giving dopamine, we give something that's a little bit smaller than dopamine, okay? And something that the blood-brain barrier does not know to block, and that's actually levodopa. And you may have heard of levodopa because it's a part of carbidopa-levodopa, which is Sinemet, which is one of the Parkinson's medicines. And so if we give this levodopa and your body takes it up into the bloodstream and then it is able to cross this blood-brain barrier, well, then you're able to actually use your own hardware in your brain to transfer it to dopamine, to convert it to dopamine, and you'll get more dopamine. And so that's one way that a person could make more dopamine, and that medication is available. We'll talk more about that. One way to increase the amount of dopamine available in the body is kind of just to prevent its breakdown. And we do have medications that work along that mechanism as well. And how about we just can't make more dopamine? How about we just act on the dopamine receptor? So if you see here, it's kind of like a lock and key mechanism. The dopamine sits on that receptor to fire the second cell. Well, what if I just create something that the body thinks is dopamine? It acts on that receptor. That would work too, and that kind of therapy is actually available. And then there's another way of activating this second cell and kind of fooling the body into thinking that there's more dopamine. What if there's other receptors? What if there's other ways of generating this signal without relying on dopamine? And that's available as well. And so now that we kind of think about things on this level, we'll understand more about how these medications interact. Now I'm going to kind of make it much more complicated. That was a little bit of a simplified version of the schematic, and now it gets much more complicated, but bear with me. I'm going to walk you through this, and hopefully it will make sense. So we're going to focus on just part of this really complex diagram at a time, and I'm going to break it down for you. So here is one cell, okay, one brain cell, and its goal is to talk to this brain cell that's just up and to the right of it, right? And so it has a signal and it needs to connect to this second cell by using dopamine across that synapse, that small little gap, okay? And I need to give it more dopamine than it would have otherwise. And so what if I give it that levodopa? What if I give it a precursor so that it's allowed to use its own enzymes and create more dopamine in these little pockets to release into this gap? And that's kind of what we think of as carbidopa, levodopa. And that's probably one of the most natural ways to allow the body to produce more dopamine. And some people will even say it's kind of like the dopamine vitamin. And we've had this medicine for a long time. For over 50 years, we've been using this medicine. We call it one of the more natural forms of treatment. Some doctors refer to it that way anyway, because it's actually in its building block, it's an amino acid. So it's a protein building block. So it's kind of formed from something natural. And how it happens is that you take the pill, okay, it goes all the way down to your small intestine, and then it's absorbed into the blood. And just like we said before, it's allowed to cross that blood-brain barrier. And once it does, it goes into your brain, where your brain uses its own enzymes to convert it to dopamine. And it uses this enzyme that we call the aromatic amino acid decarboxylase, whatever, right? And then we kind of look at what the profile is of improvement. And so if generally speaking, if I'm starting a patient on carbidopa, levodopa, and we have a follow-up visit, we always kind of talk about, well, what were the benefits that you've noticed since you started this medicine? And we don't say that because I just want to test them. It's because everybody's response to this medicine is different. Some people have tremor benefit from it, but not everybody. Some people have slowness and stiffness respond to it, and that's something we expect a little bit more necessarily than the tremor benefit. Some people will find that their gait also benefits, but others will not. And so it's important for us to know what your benefit is when you start this medicine, and also, side effects, and if we can troubleshoot those. So you may be wondering why in the world it's conjoined with carbidopa, and that's because this medicine, if it's not taken in conjunction with carbidopa, would cause an enormous amount of flushing and vomiting and generally feeling unwell, okay? And that's because levodopa, as soon as it hits the body, it wants to be converted to dopamine. It really there's a lot of enzymes in that body, that AAAD enzyme, that's all over the body. And so as soon as you take it in, if it's converted from levodopa to dopamine in the blood vessels, you get flushing. If it's converted in the gut, you're going to get nausea, vomiting. You can get low blood pressure. You can get confusion. And so all of these side effects, most of them, I shouldn't say all, generally happen because of this, what we call this peripheral conversion, or conversion to dopamine, where you don't want it to be converted to. You want all of it to be converted in the brain, but that doesn't happen. And so carbidopa helps us prevent conversion of levodopa to dopamine in places that you don't want that to happen, like in your gut, like in your blood vessels. And so the combination of carbidopa, levodopa really helps to minimize those side effects, okay? There are definitely still people who will have nausea despite having carbidopa conjoined with levodopa. And sometimes we're, in clinical practice, we're adding more carbidopa, or we're adding an anti-nausea pill directly with the hopes that we will lead to better tolerability of this medicine. The medicine, the former trade name of it, Sinemet, literally comes from sin, meaning without, emet, meaning emesis, so without vomiting. That's what they named this medicine over 50 years ago when it was developed, because it was thrilling to them that they devised a formulation that did not make people so uncomfortable and vomiting as did levodopa itself. And so you'll hear your doc interchangeably use Sinemet and carbidopa, levodopa. Yeah, so we talked about this. What about the carbidopa? Carbidopa blocks conversion of levodopa to dopamine outside the brain. And then the question is, well, how much carbidopa do you need per dose of levodopa? And I would answer that with generally you need about 25 milligrams for every 100 milligrams. And there are a few strengths of this carbidopa, levodopa. There are three. Generally speaking, you will be given 25-100. I urge you to look at your pill bottle and make sure you're not taking the 10/100, which can often lead to more nausea, vomiting, flushing, because it's a 1-to-10 ratio instead of a 1-to-4 ratio, which is usually better tolerated. And so levodopa formulations, so look at how many iterations there are of carbidopa, levodopa. So the Sinemet that we talk about is the immediate release formulation. Then there's a carbidopa, levodopa controlled release formulation, which is a tablet form. This is also an older version of the extended release. Since 2015, we also have carbidopa, levodopa extended release, which is a capsule that we call Rytari. It's composed of beads that basically dissolve at different time points to allow a more continued release of this medicine. There is an orally disintegrating tablet, ODT, that we call Parcopa. A lot of people think that this must act much sooner in terms of onset of action, but this, even though it dissolves under the tongue, still the medicine has to travel all the way to the small intestine to get absorbed, and so it winds up that time of onset is about the same. The reason we use Parcopa is because there are some people who have difficulties swallowing, and so they can still receive the medication without needing to swallow a pill. There is something you may have heard of as Duopa, which is a carbidopa, levodopa intestinal gel infusion. In Europe, they call it Duodopa. We've had this for a while as well. It requires a person to wear an infusion pump during the day. Well, I think we'll talk about that later. And then the newest of the bunch is inhaled levodopa, which is Inbrija. And you notice that there's no carbidopa in that. It is assuming that a person is also taking a carbidopa, levodopa form above, and it basically hijacks some of that carbidopa, so you don't have those side effects. And the Inbrija, this inhaled, is kind of just like an inhaler. So the question that we kind of always come back to, there's always a lot of questions of how do I take my medicine? Do I eat? Do I not eat? Where do we go with it? And generally speaking, everybody has a different understanding of this, and including doctors, about what to tell their patients who have Parkinson's. And so the strict textbook answer about this question is that you should avoid protein 30 minutes before and 60 minutes after levodopa, and that will help optimize efficacy of the medicine. Basically optimize how much of the medicine is taken up in the small intestine to the bloodstream to reach the brain, okay? But that doesn't mean that if you ate a burger and had some ice cream and took your medicine, you would get none of it. It just means that you would get less. And why is that? Well, protein, like in your ice cream, breaks down to amino acids, and so does, it breaks down to amino acids, and it requires a certain receptor in the gut to take those up, right, for nutrition. The levodopa is also using an amino acid receptor, and so they're fighting for the same receptors in the gut to be taken to the bloodstream. And if they have to compete, there's going to be less levodopa taken up at the time that there's a large meal of protein. It's not an all or none phenomenon, so you should be having some levodopa absorbed even if you do have high protein meal. And the question is, what's the exact ratio? That's something that is hard to give a number to. Generally speaking, my advice is in the early stages of Parkinson's, when there's not a lot of what we call wearing off, we'll talk about that a little bit more later, people can ignore this recommendation, because if they have plus or minus 20 or 30% of the medicine absorbed to their gut, they may not notice a whole lot of difference. So for people who say, you know, if I miss a dose, if I'm late on a dose, I don't notice any worsening, they're probably the same people that if they had a burger or not had a burger, they wouldn't really notice the difference in efficacy of their medicine. Sometimes people are exquisitely sensitive to having high protein meals, and those are the people that really need to abide by this kind of time restriction. So hopefully that answers the question for some people out there that have this question. Okay, so levodopa, common misconceptions. There are a lot of people that have fears about starting carbidopa levodopa. And the reason that these fears have come about is because of prior medical advice from physicians. And as we know, with anything in science, what we understand something to be true at one time point may not be what we understand for it to be true 20 or 30 years later. And so previously, the common practice would be to withhold levodopa as long as possible. When symptoms were mild, you wouldn't give it. You would probably try to wait as long as possible, because the thought was that sooner or later, it wouldn't work anymore. You would have an expiration date on how long you could have a benefit. And so if you're reading these bullet points, I'll give you some time to read them. There's some reasons, some things that people say when they come to see me in clinic as to why we shouldn't do these anymore. We shouldn't take carbidopa, levodopa early on. And the good thing is that there's a lot of new evidence that shows us, well, that's just not true. And I'm going to walk you through this graph, because this is one of the most powerful graphs that we have in understanding why those statements and feelings are not true, and why we should be comfortable in taking this medicine and getting benefit as early as we feel that it's necessary. So let me walk you through this. So on the y-axis, let me see, we have dopaminergic neuron loss. So this is loss of dopamine producing neurons, okay? And on this axis, we have time, okay? So we know that non-motor symptoms, things like loss of sense of smell, constipation, REM sleep behavior disorder, really vivid dreaming, tends to precede motor symptoms for some people. And perhaps there is a slow amount of dopaminergic loss that happens early on. And we see that the dopaminergic loss, the loss of these dopamine producing cells, can continue to be lost, and you may not even have any motor symptoms. And so where this purple bar starts along the x-axis is where the time of motor symptom onset may occur, and there may already be a considerable amount of dopamine neuron loss. And you can see this hash mark is, there's about 60% of dopamine neuron loss at the time of motor symptom onset. So you've lost a large amount of dopamine producing capabilities at that point. So around here would probably be the more mild motor symptoms. And of course, the trend does not stop. There's more and more dopamine loss as the years go on. And the reason, I'm going to try to have you understand why people think that there's an expiration date to medicine and why people think that there's a loss of efficacy over time. It's not related to the medicine, it's related to what we understand of disease progression. So follow me here. So let's say I meet a person at whatever this time point is, right? So over here, this is about 70% dopaminergic loss. Oh, my cursor is here. Okay, so as a movement disorder neurologist, it's my job to basically replenish the amount of dopamine loss that is going to bring somebody back to 100%, so they feel like they're motorically normal. Well, okay, that's fine. Let's say I can do that. Now we march out a little bit further on this curve, okay? And let's say we're here. Okay, now I have 80% dopaminergic neuron loss. Okay, and I'm responsible as the movement disorder neurologist to give medications to replete that huge void of dopamine, right? Well, you can imagine that it gets harder and harder because as we get, as the medication requirement increases, so does the potential for running into side effects, right? And so the job on the doc side gets harder and harder. Okay, and we often run into problems because of that. And so if we go back, let me see if I can go back. Yeah, if we go back to, it'll stop working after a few years. I'll develop a tolerance. Well, those aren't actually true, and the reason being is because over time, the dopamine population of neurons is less and less, and the job gets harder and harder. I'm going to go back one more time. The point of avoiding levodopa so I will not get dyskinesias, we've also studied, I don't have a pretty graph to illustrate the point there, but we know that dyskinesias happen in Parkinson's, not to everybody, but to most people. And that carbidopa, levodopa alone, if it's given to a person who does not have Parkinson's disease, will not cause dyskinesia. So it's this combination of medicine and disease process that leads to those movements. And the risk for dyskinesia increases as the number of years with the condition increases, okay? The other point of I'm scared levodopa will cause progression of my disease is another point that is not valid as far as the literature shows. I forgot to put in a slide. I should have put in a slide. There was some new data out over the past year that demonstrates the utility of taking vitamin B12 and folate to prevent any sort of inflammatory state that could come with the use of carbidopa, levodopa. And that gets into a little bit of biochemistry, but most movement neurologists are now advising people to start taking a vitamin B12 and a folate. There we go. Oh yeah, and there was also the LEAP trial. This is from the New England Journal of Medicine. This is a comparison of patients who had started levodopa early versus 40 weeks later, and then compared how early their dyskinesias started, how early their motor fluctuations started, so the process of off and on, and also looked at disease progression, and found no difference in those that started levodopa early versus levodopa later. And this was one of the more rigorous studies looking at these questions before we had other data, but it was purely observational. So this has added some support to the comfort that early use of levodopa is a good thing for people that need it. Okay, so we talked the most about carbidopa, levodopa. It is the gold standard. And now I'm going to take you to a different part of how the dopamine cells connect and how that transmission occurs and what other medicines we have available. Okay, so we circle here something we call the dopamine agonist. So the the mechanism of action here is that instead of increasing the levels of dopamine, we're just going to act directly on the receptor that the dopamine should typically like lock and key into and increase the function that way. So we're basically going to trick the body in thinking that more dopamine is available. Okay, and so dopamine agonist formulations, there are 4 of this class of medication available. There is Mirapex pramipexole, which is a pill, Ropinirole Requip, which is also a pill. The next one, Nupro or Rotigotine, is a patch that you do once a day. And the first 2 are either a once a day extended release or a 3 times a day. And then the last one, apomorphine apokin injection, is a rescue medicine that we use for wearing off. We'll talk about it a little bit later. So dopamine agonists. So these are things that we were just talking about. They act on the dopamine receptor. Like I said, you can have a pill or a patch. Actually, the 4th one was an injection, so there's also that. They can be dosed 1 or 3 times a day, depending on the formulation. You can take them alone or in conjunction with other Parkinson's meds, such as carbidopa, levodopa. The thing that's important to talk about is the side effect profile, and sometimes we steer away from these because of the side effect profile. They can cause sleep attacks and sleepiness, so like real significant waves of sleepiness that can come during the day. Interestingly enough, they can also cause insomnia. They can cause confusion, hallucinations, and the last one, in a minority of people, can cause impulse control disorder. So movement disorder neurologists love to talk about this one because if we don't, nobody does. But it's this, definitely a minority of people may experience this. A tendency to be compulsive about things such as eating, gambling, sex, shopping. The most interesting one I've seen is reorganizing the garage multiple times. So kind of like purposeless behaviors that happen, some of them can be really harmful to a person or their family. And so it's something that we all like to talk about a lot to make sure that individuals and family members know about this and keep an eye on. So if they did occur, that we would definitely modify medication choices. All right, so that was dopamine agonists. Where are we going next in this picture? So these 2 arrows basically denote the recycling process of dopamine. So there's dopamine neurons, these dopamine cells, and they need to talk from one cell to the next, right? But the important part of this process is that dopamine does not hang out in that synapse for longer than what is necessary for one cell to talk to the next, because if it is there for too long, you'll have purposeless firing, you'll have persistent firing, and movements will be very erratic. Okay, and so that dopamine signal needs to be recycled and taken away from that synapse so cells don't overfire. And so there are enzymes, MAO-B and COMT, whose job it is to recycle the dopamine or other neurotransmitter. And this blue blob also denotes that there are many supportive cells. So for each like dopamine producing cell or other type of neurotransmitter cell, there are many, many supportive cells that you can see the name for it here, glial cells. Their job is just to make sure that at the forefront are the dopamine cells, or let's say the serotonin cells or other cells, and that their neurotransmitters are recycled. So we have 2 enzymes that we know about that recycle, all right? So we take the first one, the MAO-B inhibitor. So MAO-B is the enzyme, and the inhibitor is the enzyme that is the medication that blocks that process. And we have some medications that do this too. Selegiline is completely generic at this point, so we no longer talk about Aldapril or Zelapar. Rasagiline, which a lot of people have heard the name of, much more so than Selegiline. Formerly trade name was Azilect. And then cyphinamide, which is much more recently FDA approved, also known as Xadago. That this last one is only FDA approved to be used in conjunction with other Parkinson's meds. The first two can be used as monotherapy, meaning alone, okay? It's important to think about these medicines as being weaker than the carbidopa, levodopa, and the dopamine agonists, meaning that their ability to reduce Parkinson's motor symptom is not as robust, if that makes sense. Azilect was approved, I believe, in 2006, and when that came about, there were initial studies that showed that it could potentially be a disease-modifying therapy. And so disease-modifying meaning basically slowing the progression of Parkinson's disease. And so everybody jumped on that and was prescribing Azilect for, their patients in the hopes that we could halt where this condition is going in terms of progression. But then we had some studies that showed that disease modification is not true, that it was not replicable, we should say. And so we use this medication as a symptom management, just like we do for all of Parkinson's medications. They're all symptom management. And there's no longer the additional benefit of disease modification, which is something that we're all hoping will be part of treatment someday. So the reason I bring that up and the time of approval is because it's important, if you're on Azilect, to discuss with your doctor why you are on Azilect, and not for disease modification, but for symptom management and how much of a role it's playing in your treatment. There are a lot of patients who are spending a lot of money on Rasagiline. And it's just important to know that if it is financially straining, that it is worth it. So definitely bring that home to your doc and talk about the use of these medicines. Ultimately, it kind of feels like these medicines will smooth out things a little bit. So in terms of people that have motor fluctuation, these medicines kind of smooth out the dopamine levels. So MAO-B inhibitors, this same class of medicine we're talking about, they come with a little bit of baggage. The side effects in the middle of this slide here can sometimes be a reason to stop the medicine. So you can have lower blood pressure, or also episodes of severe high blood pressure, headache, nausea, dizziness, constipation. And there's a lot of restrictions with this class of medication. You must avoid the things that we talked about that are listed here. And also there was formerly a restriction of red wine, aged cheese, and other things. The tyramine avoidance recommendations, so these dietary restrictions, that has recently been a thing that we understand to not be necessary. So most people can still have some red wine or aged cheese and not worry about a complication that we call a hypertensive crisis. But there definitely are restrictions related to other supplements and medicines. And there's also the big problem is an antidepressant interaction. There's a number of people with Parkinson's who have anxiety, depression, and rely on certain medications to help mood, and Rasagiline limits the choices available and the doses of those choices. So, MAO-B inhibitors, it's important to advertise this if you're on them. So if you're going to the pharmacy to treat a common cold and you're on Azilect, let's say, you should really be having a discussion with the pharmacist of what can and what can I not take if I'm also taking my Azilect. You see here that dextromethorphan, which is a common part of cough medicine, and Robitussin is something that you should really not be taking. Tramadol is a pain medicine that many people do take, especially in the post-operative period for people who have orthopedic things in particular. And so you know, I tell my patients, if you're on Azilect, advertise it. Make sure all of your doctors know about it. And they should be so tired of hearing you say, I'm on Azilect. Okay, COMT inhibitor, so that's that other enzyme that helps break down or helps prevent, I'm sorry, COMT recycles the dopamine and the inhibitor will keep it available instead of allowing it to break down. COMT inhibitor is a little bit different because it actually acts outside of the brain. So the initial figure that I showed you where it made it look like it was in the brain, forgive me, it actually is outside of the brain and will inactivate levodopa before it crosses the blood-brain barrier. There's a couple forms of this, and this is actually, this reflects the most recent medication added to our arsenal. Entacapone is the old one, so Comtan, which you may or may not be familiar with. More like 10 years ago, 15 years ago, 20 years ago, Stalevo was what people would be talking about, which was carbidopa, levodopa, and entacapone together. So carbidopa, levodopa, we already talked about. We convert it to dopamine, so our brain has more dopamine. And entacapone would help prevent the breakdown of levodopa in the blood before it crosses the blood-brain barrier. So you would basically have the most levodopa reaching the brain as possible. Entacapone only works if you take levodopa. So if somebody tried to prescribe this without that, it just would not be effective. So that takes us to opicapone Ongentys, which is the newest Parkinson's medication, FDA approved April 29th this year. It's a once daily medication and it's also a COMT inhibitor, but it doesn't need to be taken with each dose of carbidopa, levodopa as entacapone does. I X'd out tolcapone because that's no longer on the market. There was some liver toxicity associated with it, and the side effects are listed there again. I hope everybody's still following me. We're gonna go now to Neuriance. Neuriance is another pretty new medication. I think the approval was in 2019. Don't quote me on that. Definitely not 2020, but I don't think 2018. I'll have to check. Anyway, Neuriance is actually kind of like one of the medicines that we use that doesn't act on the dopamine system. So I'll go back for a second. So most of this is allowing us to make more dopamine or for dopamine to hang out in the synapse longer or to pretend to be like dopamine and directly trigger one of the receptors downstream and basically triggering that second cell in those mechanisms. What we're doing with Neuriance is to basically act on a different receptor, something that's not even depicted in that complicated scheme on this slide. And what it does is it decreases one of the dopamine receptors, the type of receptor that actually acts in opposite of what we want our dopamine receptor to. So now this is like Parkinson's 501, and I'm not going to explain the mechanism behind all of this because it is kind of like your head would be in the clouds. But basically, it's an indirect way of stimulating the dopamine neuron without exposing the dopamine neuron to more dopamine itself, but by using something called an adenosine receptor. And Neuriance is actually a metabolite of caffeine. And the side effect profile is there. It's something that is similar to medicines that we see for other avenues of treating Parkinson's disease. So this is it's kind of like these are the usual suspects in terms of side effects. Where are we going now? Now we're going to a different receptor. So we went to the adenosine receptor, which wasn't even on this diagram, because neuroscience is relatively new. And next we're going to the NMDA receptor, and we find that if we block this receptor, we can have some action that helps with Parkinson's related symptoms. So amantadine, you may have heard of amantadine. It was originally a medicine that was used to help reduce and minimize the symptoms of flu. And we found that some people who took this medicine had reduction in Parkinson's symptoms. So there was a reduction of tremor, or there was a reduction of dyskinesia. And the dyskinesia reduction is probably the most compelling symptom improvement. It has a complex mechanism of action. It actually works several ways that makes our diagram much more complicated than where it is. The side effect profile is a reason that we have to make sure the individual is the right candidate for this medicine, that the risk-benefit ratio really does favor use of this medicine. Generally speaking, we avoid prescribing this in people that are showing signs of cognitive impairment, anybody who's prone to having hallucinations, because we know that the biggest side effect with amantadine is actually hallucinations and increased confusion. Also can find a particular pattern of leg swelling or a lacy type rash that looks like fishnet stockings on the lower extremities in particular, and we'll have to dose modify. We need to know about kidney dysfunction before using this medicine because the toxicity and the tolerability is different if that applies. Amantadine Formulations. So here's where the past 3 years have changed things pretty dramatically for us. Amantadine IR, immediate release, has been around for years. We dose this medicine usually 2 or 3 times a day. We typically avoid nighttime dosing so that we're not contributing to any potential for confusion with that process that we call sundowning, where a person may get more confused in the evening. There have been 2 new additions to the market in the past 3 years. One is GoCovery and one is Osmolex, and these are extended release versions of amantadine. GoCovery is actually taken at night. There's a delay before onset of action of this medicine that occurs during the morning waking hours. Osmolex is taken directly in the morning, and both of those drugs, number 2 and number 3, allow for once-a-day dosing. So trihexyphenidyl/artine, this is an old medicine, and it has its usefulness. It also has its problems, and so you'll generally not see this one used very frequently. It can be quite helpful for people with tremor and dystonia that's not responsive to other medicines. So dystonia, we haven't talked about that yet. That's a symptom in Parkinson's, or it's a standalone condition where there is an abnormal contracture or posture, or it's usually a toe curling, a foot scooping inward, a ballerina toe phenomenon, or a neck turning to one side or dipping forward. And those are the reasons that we turn to it: tremor or dystonia. It has a mild potency, meaning a mild ability to help with symptoms. The problem with this medicine is it has a pretty poor side effect profile. So you see that generally speaking, people will get dry mouth usually, and they'll feel like their head is in the clouds, especially at higher doses. The older a person is, the worse they tolerate this medicine. Kids, actually, we use this in pediatric neurology very often in kids who have dystonia, and they can tolerate both loads of this stuff without having much problems in school or anything, and there's just is not tolerated well with an older metabolism. Okay, so here's where I typically take a break and give people a rest. I'm gonna just turn to Alina for a second. Are there questions that we should answer now, Alina, as a way to take a break, or do you want me to keep going?
Dr. Solis-Cohen, this is Jody. Elena may have just stepped away very quickly.
Oh, sure.
And I'm kind of looking to see if there's anything as far as questions. Hold on one moment.
Sorry, I'm back now.
That's all right. So far, there have been no questions from the audience.
Okay.
If we want to why don't we take a couple minutes, and if anyone has questions on the first part of that presentation, if you can either raise your hand or put them into the chat session now, but we'll just take a couple minutes and let people do that so they can maybe get some questions out, because that was a lot of information.
Right.
So, and then Elena, I'm going to let you take back over if you are back.
I am. Sorry about that.
Right, no worries. No, that's why I was like, you may have stepped away. I'm going to mute myself again.
Okay. Yeah, so go ahead and ask any questions. Type them into the questions drop-down tab if you've got any, or if you want to raise your hand and ask your question in person, that is also an option for you. Okay, so we'll go ahead and get started with our second half of the presentation, if that's all right with you.
Sounds good.
Great.
All right. So next we're going to go, oh, I think I know what I have to do. Give me a second. All right. So motor fluctuations. So I said we were going to go here. What are motor fluctuations? They don't apply to everyone, but it's important to know, are you having motor fluctuations? And motor fluctuations basically refer to an experience of on versus off periods during the day. So it's periods related to medications working, where you'll have periods of slowness, stiffness, tremor that are improved by the medication. And then that's followed by a return of the Parkinson's symptoms that we call the off period. So you'll hear about us talking about on periods and off periods and motor fluctuations. You'll hear some people talk about end of dose wearing off. So the phenomenon that dose of carbidopa, levodopa, let's say, lasts X many hours after it's being taken. For some people, that's longer. For some people, that's shorter. And not everybody has this. That may be a function of the stage of Parkinson's, the types of medications they're on, the flavor of Parkinson's they have. You know, we think about Parkinson's as more of this umbrella diagnosis where yes, people qualify as having the condition, but there are so many different varieties of it that we know that people's responses to medicines are different, people's rate of progression is different, and just the overall experience is different. So there are motor fluctuations. There are, it gets even more complicated because there can be what we call non-motor fluctuations, where we have fluctuations in energy levels, fluctuations in anxiety and depression as well. And those non-motor fluctuations we're just going to ignore for the purpose of this talk. We're just going to focus on the motor fluctuations. So I really like this depiction because I think it helps illustrate what's actually going on here. I'm going to walk you through this graph a little bit, just trying to allow myself to see it. 1 second. All right, so on the y-axis up here, we basically have different motor function states. So down here in this pale blue bar is the off state. So kind of like when you have return of slowness, stiffness, and tremor, okay? The on state, that's when things are working well. You're having less slowness, stiffness, tremor because your medicines are working well and it feels like things are well controlled. And then up here in another pale blue bar is on with dyskinesia. Dyskinesia is the term we use to refer to extra wiggly type movements that you see in those with Parkinson's. And so let's take a person through their day and see how a person's levodopa levels, or dopamine levels, affect their motor state, okay? So for this person in particular, the beginning of the day, they take their first L-Dopa or levodopa dose, right? They have an increase in the amount of dopamine that they're able to produce, and then it kind of dips again, and then they take their second carbidopa levodopa dose, and then an increase in how much levodopa that they experience. And so there are these kind of peaks and valleys, especially for most people. They have these peaks and valleys of how they look during the day. But look at this. For this individual, despite the fact that they're having peaks and valleys, this kind of pattern, this sinusoidal pattern, remains within this darker blue bar, telling us that despite that, they're well controlled. They're still just on. They never crossed into on with dyskinesias. They never dip into the off state. Now, this is very different than a person who's experiencing this. Here's a very different symptom profile. So the day for this individual starts out in the off state. A dose of levodopa leads to a dramatic increase in levodopa or dopamine levels. And then they transition from the off state here to the on state, here to the on state with dyskinesias. And then their level drops again back into the on state, and then again into the off state where they dose again. And so this person is definitely experiencing motor fluctuations. They're having this roller coaster phenomenon of going from the off to the on with dyskinesias, down to the on to the off. So this day for them can be very frustrating and very exhausting. So on with bothersome dyskinesias, it's important to clarify what these wiggly movements are and when you have them, because of course there are other involuntary movements in Parkinson's, like tremor, like dystonia. And so it's important to kind of come to a conclusion with your neurologist about a certain movement that you have and how to classify it. Otherwise, you may be treating things the wrong way or inadvertently increasing your dose when you should be decreasing it or so forth. So our dyskinesias, tremors, they are not, and it's important to get an understanding of that. So I generally like to show a video. I don't know if I can in this process, but it looks like I can. So hopefully you guys can hear this and even see this, and I'll be quiet.
Our first guest is a 5-time Emmy Award winner and a noted philanthropist. His foundation has raised more than $450 million. 450.
Whoops. Okay. Something I did wrong. I think I'm going to skip it for the sake of it, but if anybody goes to observe Michael J. Fox on YouTube, especially more recently, he has a very good demonstration of dyskinesia. My apologies, but I don't feel like surfing the web with you guys right now, so I'm going to skip it. And when he has the wiggly extra tight movements, it's important to know that those are dyskinesias, and they're generally probably, if you ask him, are they bothersome? He'll probably say they're not that bothersome. They're just more bothersome to people that are watching him because they think that he's anxious or uncomfortable. And that's one of the take-home messages of dyskinesias, is that it's generally more bothersome for the person that's observing than the person who's experiencing them, until they lead to difficulties with gait, like they can lead to falling or, you know, potentially even injury if an arm swings out too far that it injured, you know, you wind up getting hurt. And what do we know about what causes dyskinesias? Well, we know it's related to dopamine. There is that process of dopamine loss that is in conjunction with dopamine pulses from medication, as well as glutamate activity. All of this kind of process leads to the production of dyskinesias. So one of the ways that we try to help simplify this very complicated process of learning about an individual and their various motor states, and then trying to act on the state that is most prevalent, most bothersome, or adjust to the ever-changing person, is to keep a Parkinson's disease motor diary. And I often advocate this in clinic. It's definitely time consuming for both you and your neurologist to go through a Parkinson's diary, but especially when a person is fluctuating like this, it's kind of the only way to do it. And so I'm going to show you a way to keep a diary on the next slide. This slide, we're talking about basically putting yourself into a box for a certain time period, and whether you're asleep, whether you're on in a functional state, whether you're on with bothersome dyskinesias, and so the dyskinesias are actually impairing you and they need to be adjusted, or you're in an off state where you have return of the slowness, stiffness, and tremor. And so if you were forced to put yourself in one of those 4 categories and then keep a diary during the day, you'd wind up with something like this, where you start at midnight, and this this diary is something that you can find here, parkinsons.ba.gov resources, where you kind of like need to put yourself in a box every half an hour and put which one of those 4 states you're in. And just doing this is very helpful in communicating a message to your neurologist about what's going on with you during the day. I have one too. Let's see. I have one too, and it looks like this. I cut down the work by the time period of the box being every hour, but still the 4 states are there. And mine puts also the medications and what time those were taken, so that I can interpret the graph in terms of those. And so it's not uncommon that I will ask people for this kind of a homework assignment to help understand what they're going through at home, knowing that just because I see them at 12:30 when they're on with troublesome dyskinesias doesn't mean that I need to tailor my therapy for that snapshot in time when look at all the other things they're going throughout the day. So this kind of a thing, and feel free to take and modify this diary, is very helpful. So types of off periods, even though we said one of those 4 boxes of what kind of a state you could be in is an off period, there's actually different ways that we look at off periods to adjust medicines as kind of the treating physician. And so one of those off periods is early wearing off before the next dose. So it feels like the effect kind of peters out before the next dose. Well, that's a really good thing to pick up on from the diary, because you have a few options there. Maybe you extend the life of the medicine, or maybe you try to add a long-acting medicine. Maybe you make the interval between the doses shorter so that it doesn't have to last as long. But picking up on that trend from the diary is very helpful for some people. If you find that you're always off in the morning before your first dose, well, that's pretty that's a reliable trend that you can pick up on and try to treat and really make mornings better for people. Or what if you find sudden unpredictable offs? What if it, and I talked about this earlier today with somebody. So sudden unpredictable offs is the phenomenon that you can just suddenly shut off, regardless if it was an hour after a dose or 3 hours after a dose. And it doesn't matter what you do, what you eat, you can just shut off. That's the hardest to deal with, and that requires its own set of tools in the toolbox to deal with. So here's what can we do about off time. We're often discussing this in clinic. So like I said, you can change the timing where you're doing more frequent doses during the day. You can actually increase the dose so that the dose will last longer. That's another way of going about it. You can then switch to an extended release formulation. So we were saying things like the carbidopa levodopa extended release, or Rytari, or the extended release dopamine agonist. You can add these inhibitors, which will prolong the action of dopamine by preventing it from being broken down. You can add that the agonist, and then you can add a rescue medication. So a rescue medication, what is that? Well, we talked about them, but now I'm going to talk about them in their role as a rescue agent. So Apokyn, like I said, it was an injection medicine, and it basically allows you to achieve a faster on time than your oral medicine. Generally speaking, the best you can do with an oral medication to expedite its onset of action, and I don't recommend this for everybody, and it only works for carbidopa levodopa immediate release, is to chew it with some seltzer. Some people say orange juice. Most of the time, Parkinson's medication should not be chewed, and they should be swallowed whole, but the only exception is the immediate release. That's the only time that you can try to hasten its onset. Anyway, if you're not doing that, then you should be using these rescue medicines, one of which is Apokyn, which is kind of like if people have seen an EpiPen, where it's a pre-filled injector, and if you find yourself in a sudden off state or an early morning off state, you inject and you get a faster on. Inbrija is that inhaled levodopa, and that we also use as a rescue medication to lead to turning on more quickly than the oral medications do. So what else do we learn from those motor diaries? And I urge you guys to do those motor diaries at home if you're dealing with motor fluctuations, to talk with your neurologist. But what do you do if you find dyskinesias? Well, one of the things that we do is we can consider lowering the levodopa dose, because high levodopa doses contribute to that process. You can increase the interval between levodopa doses. You can eliminate the extenders. So if you're on carbidopa, levodopa, and Azelac and Mirapex, then you kind of just help eliminate maybe the Azelac, or maybe half the Mirapex. The other option is to keep your dopamine medicine the same, but to add amantadine, which is known to be an anti-dyskinesia medicine. And what happens next? What happens if all of the medicines that we talked about thus far does not lead to an acceptable on state? What if we're just still in between a rock and a hard place? Well, we have some other therapies to turn to, and this is what we're talking about in terms of more advanced therapeutics. So we have this levodopa intestinal gel infusion, and this is, again, that gold standard medicine, the carbidopa levodopa, but this time it's a gel suspension. It's been around since 2015. Europe has been using this for much longer than us, and you see this carrying cartridge here. So basically the Duopa, the suspension gel is in this bottom part, and here's the infusion pump up here. And for 16 hours or sometimes more, there is a continuous infusion through this tubing directly through an opening in the skin into the small intestine. And so it bypasses any potential delay of transit time through the stomach, if the stomach is affected by the Parkinson's disease as well. It smooths out motor fluctuations that kind of spiraling up and down related to the blood concentrations of levodopa. And most of the time it obviates the need for oral medication. So most of the time you're just doing this and not your orals. So more about this medication in terms of the logistics. The cartridges, this part that kind of detaches from the system, and you throw the cartridge away after using it. You take a fresh one from the fridge because it needs to be refrigerated, and you hook it up and you're good to go. Some people go through 1 cartridge a day. Some people go through, I think the most I've seen was 2. The cartridge and the infusion pump can be worn as a fanny pack or in a belt or in a thing that looks like a little purse. There's a lot of different ways to like wear it. It replaces, like I said, most, if not all, of the daytime pills. And you unhook it at night, you flush the tubing, and you go to sleep. If you're going to go for a swim, you unhook it, you go for a swim. The company that deals with the Duopa system has been very good about making sure that patients are educated and comfortable, as well as their family members, and how this therapy works. And again, that goal is smoothing out motor fluctuations. So an alternative to using Duopa, which is that intestinal gel infusion, is deep brain stimulation therapy. That's something that you guys probably have heard about in other educational seminars, so I'm only going to talk about very briefly now, although, you know, we could be talking for hours and hours on deep brain stimulation. So deep brain stimulation therapy uses a low electrical current in the deep brain structures through a electrode that's implanted inside the brain. This is a therapy that has been approved for a long time. We've been using this for over 20 years. And there are indications for tremor outside of Parkinson's, Parkinson's itself, and dystonia for individuals who don't have Parkinson's but just have another form of dystonia. The goals of DBS and Parkinson's disease, one of the major goals is to smooth out those motor fluctuations so they feel like the people feel like there's a more consistent on state, to reduce tremor that may be refractory to medication. So despite all the medications when we throw at a tremor, sometimes it does not want to stop. To independently reduce dyskinesia, help dystonia. The whole question of does my walking benefit from DBS is a tricky one. It's much more clear that the walking will benefit from DBS if it is also responsive to the medicines. If the walking is not responsive to the medicines and what we call levodopa responsive, then it's less likely to respond. And use of deep brain stimulation may reduce medications, but really the expectation is that medications will be necessary moving forward, and the goal is not to eliminate medications, but maybe reduce. The DBS process is something that doesn't happen overnight. It's a lengthy one for the neurologist, the neurosurgeon, the neuropsychologist who looks at the cognitive aspects, to kind of make this team approach of strategizing if this is going to lead to the outcome that the patient wants and if this is in the patient's best interest. So we look at things like cognition. Are there memory impairments? Are there hallucinations? Are these symptoms levodopa responsive, meaning are the medications helping? Does the patient have reasonable support so they can return to clinic for multiple programming sessions later on? And we go through this pretty lengthy checklist and numerous visits to make sure that both sides of it, the patient and all of the providers, agree that this is the right move. I've seen it happen numerous times where we're not on the same page necessarily, that the patient thought one thing, they were going to get this out of DBS, and the provider it didn't completely understand what the individual was thinking. And so it's always really important to see your doctor numerous times to talk about what you think you're going to be getting out of it. Ask your doctor what they think you're going to be getting out of it to make sure that it's worth your while and it is appropriate. There's many different ways of doing this surgery. So another important part to hone in on is how the surgery is going to be done and what is the neurosurgical experience of your surgeon and what technique do they do, because there are different techniques these days. And then after the surgery, the neurologist steps back in. So we're talking about typically a movement disorder neurologist who does the programming. And it's not a one and done. This is a thing that happens over the course of typically 6 to 12 months to get programming to a state that is stable. And then there may be additional programming down the road from there. So as you can imagine, for people that live far from their programming movement disorder neurologist, things can be somewhat complicated. So when is the right time for DBS? We've changed our answer to this. We used to say that DBS was for people that are have tried everything, that they are motor fluctuating despite optimizing medication. And now we say that we would support deep brain stimulation for those with 4 years of symptoms, of motor symptoms, and they just have early fluctuations, because we know that early DBS has actually led to better quality of life outcomes. And there's been one of our important studies surrounding the early STIM trial, which looked at this in a pretty rigorous fashion. We know that the right time for DBS is people that are using frequent doses of levodopa and still fluctuating, that they are having a good response to medication for periods of time, not all the time, and they're not having much difficulty with swallowing, speech, or walking. They have good overall health, so that they're a good surgical candidate in general, and that they have a good support system. Reasons to avoid DBS surgery are the following. So swallowing symptoms, a lot of bladder dysfunction, cognitive difficulties, speech difficulties, severe depression, and significant gait imbalance. Complications of DBS, I'm just going to kind of let you guys look at these. Anytime you're putting a electrode into the brain, there can be associated bleeding or infection. People can get confused surrounding surgery. The electrodes are connected to a wire which connects to a battery pack underneath the collarbone, and there can be a microfracture of the wire that connects that system. So DBS improvement, some of the stats that we know about. So there's a thing called the UPDRS when you go to your movement neurologist and they're asking you constantly to tap your fingers and open and close your hand and flip over your palm and do all sorts of tasks, and then try to pull you over by doing the pull test. Well, that's part of the UPDRS, which is the Unified Parkinson's Disease Rating Scale. We use that rating scale as a outcome measure for a lot of Parkinson's directed studies. And so we quantify people. We kind of come up with a number of how severe or not severe symptoms are. And we see that motor scores improve by 30 to 50%. So that's an actual number in terms of how to quantify that improvement. In my eyes, it leads to pretty notable symptom benefit. There is an increase in on time, so that's that good functional on time without dyskinesias by 4 hours or greater a day. And then there's these quality of life scales that we use to get a subjective measure from individuals of how much they've noticed improvement. And those, as you can imagine, the percentage ranges here from 17 to 50% improvement. Wondering why this is coming up again. I think I just have it twice. So when you compare DBS and Duopa, there's some reasons to think that a person should have one versus another. So like, what are the pros and cons? How do they line up? When we think about DBS, it's important to know that this is an elective brain surgery, and so there's complications potentially associated with that, and that's to be taken seriously. It's important to do this only when there's no significant walking or speech concerns, and that better outcomes happen when there's adequate support for people to be brought to appointments, and if they're having difficulty with their system, they need support, at least in the beginning. With Duopa, this is a GI surgery, so this is, some people would argue that this is a more minor surgery, and that cognitive speech walking concerns are not as much of a consideration as they are in DBS, where we would often argue against surgery in that regard. And that the role of the patient and care partner should be always available to unhook a levodopa cartridge and flush the tubing every night. A lot of people ask me about high frequency focused ultrasound. We often call this HIFU. This was approved in 2018 for tremor predominant Parkinson's. So that's people who have mostly tremor and less slowness and stiffness. It's a technique that requires the center that performs it to purchase a very expensive MRI scanner where you can use the MRI to then be compatible with ultrasound and perform this procedure. And it requires people that are highly specialized. So if you were thinking about this type of a therapy, and I'll talk a little bit more about what that means, what kind of person you should be when you're thinking about this, you should be kind of talking with movement disorder neurologists about what center they would recommend and who's got the best experience in this, because it is really operator dependent. So people who think about high frequency focused ultrasound, you can only have one side of the body fixed, basically. So one side of the brain, which modulates the opposite side of the body, can be intervened on here. And the ultrasound, the high frequency ultrasound, basically is a way to triangulate a very high frequency ultrasound to basically heat up a portion of the brain and cause what we call a lesion or an area of dysfunction. So kind of in more grotesque terms, you're kind of heating up a part of the brain to destroy it. And that was the technique that we had before deep brain stimulation. We would actually call it a pallidotomy, where a person would have such severe symptoms that a neurosurgeon would go in and actually destroy a part of the brain that was contributing to their Parkinsonian symptoms. You can imagine that the side effect profile of that may be quite striking. So high frequency focused ultrasound makes it a non-invasive procedure because there's no cutting of the scalp, but that ultrasound is triangulating a certain region of the brain that we know to be involved in tremor production, let's say, and then heating up that part of the brain so it's ultimately not functional and actually is destroyed. There is a risk of side effects with this, and because this is a one and done, this is you go in and you get the procedure and you can't modulate its effect afterwards. If you do have a side effect, it's something that stays and you can't erase. Also, if you have suboptimal tremor control with the first pass of this, you don't go back and try again. So this is the last part. You are almost done. We're talking about meds in the pipeline. So used in Europe is a subcutaneous pump. There are two things that you can infuse subcutaneous. When I say subcutaneous, I mean just below the skin surface. So you can infuse either carbidopa, levodopa, or apomorphine, which is the chemical that is in Apokyn, that injection I was talking about for the rescue medicine. So I'm waiting for this to come out. I'm excited to hopefully be able to offer this therapy to people in the future, because it is, in my mind, a relatively non-invasive way of giving a more even-keeled amount of medicine to help with allowing those plasma levels, those blood levels of levodopa to be as smooth as possible. And something that does not involve a surgery with a tube into the stomach and small intestine. The other thing that is in the pipeline that you know, a lot of movement disorder neurologists are waiting for is antibody therapy. So you may hear monoclonal antibody therapy or just antibody therapy. One of the proteins that accumulates in the dopamine neuron is called alpha-synuclein. I don't think I said that term yet today. Alpha-synuclein is a protein that will aggregate and then cause this Lewy body, which mucks up transmission in this dopamine cell. And it's basically like this protein misfolds, and it keeps folding because it's misfolded, and then it causes this neuron to not be able to function, and it can be so injured that it actually dies out. And so what if we can generate an antibody against the alpha-synuclein that's here so that the cell does not get injured and it is able to continue to function and do its job of producing dopamine? Well, that would actually be disease modifying and could halt progression of disease, or you know, even if it just slowed it, we would take that too. So we're waiting. This is something that's in phase 2 trials, and we should know more. CBD and Parkinson's disease, and you know, being in the state of Colorado, the University of Colorado is doing a number of studies about CBD and what expectations there are in terms of motor and non-motor improvement, and those are ongoing. I would definitely urge people to take part in some of those research studies. There are several centers in Denver that are doing a lot of the research about disease-modifying medications and CBD. And to help find some of those trials, you could definitely use the Michael J. Fox Foundation has a Fox trial finder where you can put in here where you're located, your zip code, and it kind of just scoots you along to find out if there are trials nearby that you're eligible for, if they're enrolling, and how to be a part of this, because it's with you know, individuals with Parkinson's that are participating in these studies that we've been able to add, you know, medication after medication to the list in this PowerPoint today of what's available. So that's where I end, and I appreciate your attention and your time. It's less fulfilling to me to do this through a webinar, so I hope people learn something that's helpful and to take back to their neurologist. I'm happy to answer questions.
Awesome. Thank you so much for that extremely thorough explanation of all the medications. We do have a question that came in from Terry, and her question is, for off times, you mentioned chewing a tab with seltzer water. Please explain how and when.
So this is only for carbidopa, levodopa immediate release. So that's the yellow tab. And the theory behind that is you're increasing the surface area by chewing it, and then either using seltzer water or orange juice, some people do both, changes the pH of how it's received into the body, so it allows it to be absorbed into the bloodstream faster. You know, this is kind of like on the order of maybe just a couple minutes faster. I don't know. It's definitely something that our field will give as an anecdotal recommendation to people if they're really waiting for their medicines to kick in.
Great. And she has another question. Terry has another question. Your thoughts about people who are anti-meds and want to use supplements?
Yeah, so I have a number of individuals who come to see me on supplements, and it's not that supplements are bad. It's just that there is a role for supplements in Parkinson's. So there is a supplement called mucuna pruriens, which is a dopamine analog, and that's a relatively weak form of what we know as carbidopa, levodopa. And so people who are relying mostly on supplements themselves, particularly that one, often have untreated motor symptoms with regards to Parkinson's. There's a huge role of other supplements. So, for example, there are studies in Parkinson's showing that vitamin D deficiency in Parkinson's is linked to poorer cognition, so poorer memory and attention. And so vitamin D, if low, needs to be supplemented. I talked about the role of vitamin B12 and folate for those that use carbidopa, levodopa in particular, and the need to take those 2 supplements. In terms of the evidence-based studies, beyond the D, B12, and folate, we don't generally recommend supplements in particular, and mostly it's because we haven't studied them, and so we don't like to make recommendations unless we've got hard evidence. So that's as much as I can say.
And a follow-up question, what is folate?
Folate. Folate is folic acid.
Gotcha. Okay, and kind of a follow-up question from myself, does that same apply to diet and nutrition? I know you mentioned it with regards to medication, but you know, some people are really curious about how diet and nutrition can help your Parkinson's symptoms.
Sure. That's funny, that came up in one of my visits today too. There's a lot of literature about Parkinson's and nutrition, and some people get very opinionated about what's actually the best, like what will lead to a better motor outcome. And I don't think we understand enough about that, because a lot of that literature is confounded. Like, you can imagine if you try to look at let's say a dairy-free diet, and if you do a study of dairy-free versus non-dairy or versus a dairy diet, there's so many confounding variables about who takes medicine, what stage of the disease they're in, who exercises or non-exercises, and we know that exercise is a huge thing. So I think it's just never a pure outcome because of how many confounding variables they are, and knowing that the study's not clean. I would probably say that the most compelling data comes from a study that came out in 2019, I think in the probably it was like March or February, from the journal JAMA, and I think it was JAMA, if it was not the New England Journal of Medicine. But the take home from that study was looking at people who had what we call prodromal PD. So that was people who had anosmia, so a reduced sense of smell, or they had REM sleep behavior disorder, which are 2 of the classic non-motor manifestations that can transform into Parkinson's disease. And I was looking at those people and following people with the Mediterranean diet or non-Mediterranean diet, and seeing was the rate of progression to Parkinson's different because of the dietary choices. And it seemed that the people that followed the Mediterranean diet had a lower rate of conversion to Parkinson's from their what we call prodromal state than those that did not follow the Mediterranean diet. So I don't know, the Mediterranean diet is a generally healthy one, and I feel comfortable recommending that to my patients. But I think people need to listen to their bodies more than anything, because I don't feel like the science behind it clearly supports eliminating dairy, or clearly supports eliminating red meat, or those kind of things. And I know I'm at least my cardiology colleagues are at least in agreement with me if I say follow the Mediterranean diet.
Yeah, awesome. Thank you. So I'll give a couple more seconds for some questions to come in. I think you did such a thorough job that everybody's questions have already been answered. I do want to mention that I found a copy of your motor diary, and I actually added it to the handout section so people can download it if they would like. So if you have an updated one, let me know. But I think I have the proper one. So that will be included in a follow-up email along with all of the other handouts and a copy of the slides. I think we don't have any other questions coming in, so we can go ahead and wrap up and call it good.
Thanks, Lena.
Awesome. Thank you so much.
Okay, bye.
Bye. Have a good one.